All right, Tom, why don't you go ahead?
Okay, so basically we're going to talk about ACS, possible ACS in the ED, and arrhythmias we see in adults. It's a little free form, so if you have any questions about anything else, just let me know and I'll be happy to speak about it. So we're going to talk about acute coronary syndrome, which this is part of those one things that we had a question on, and then also how to deal with tachycardia arrhythmias. As far as like chest pain, everybody gets concerned about heart attacks. Basically, there's 5 things that will do you in if you miss them, and heart attacks, PEs, aortic dissection, pneumothorax, esophageal rupture, other things, like bad pneumonia, respiratory failure. Sure, agree, but if you overall look pretty okay, these are the ones that if you miss it, they can cause a lot of morbidity and mortality. So when we're talking about heart attacks, really what we're talking about is myocardial infarction, and that's anytime we have ischemia, and that can be due to a variety of sources. When we see this a lot more than adults than kids, what we typically call a heart attack, and what people know about is basically type 1 MI, and that is you have plaque in your coronary artery, and the plaque ruptures, and you form a clot there of varying degrees of obstruction of the coronary artery. 100% occlusion is a STEMI, that is an ST elevation MI. You're getting no blood flow distally in the coronaries, and the heart dies. And then STEMI is you have a clot, but you still have some flow through it. You have like 30% flow left. Just it varies, so you'll have some flow, but not no flow. There's other things that can cause what a type 2 MI is. These can be the other things. These are like vasospasm if you're using coke or meth, anemia, sepsis. So you have a uroseptic 85-year-old that comes in with a heart rate of 160 and febrile to like 39 and altered, and white count of 25, and she's got a trope leak. I don't really care about that trope leak. That's just a supply-demand mismatch. Most likely, she's got some underlying coronary disease, so like stenosis, maybe 50 or 60%, and she's basically running wind sprints. That's with her heart rate so high, she's getting a trope leak. Or she could have septic cardiomyopathy, and the sepsis itself is causing a trope leak. Severe hypovolemia, severe hypertension, so on and so forth.
Can I interrupt you just for a
Yep.
minute? You're using a lot of terminology that's not pediatric terminology. Okay. So if you could just describe like what you're saying, and then just slow down a little bit, because
Sure.
people on the phones can't see the
Gotcha.
slides.
Oh, no, that's a shame. So type 1 MIs, this is ACS, acute coronary syndrome. Basically, it's a rupture in the plaque, and you get a clot there, and it's an acute event. Type 2 MIs are basically a supply-demand mismatch between how much blood the heart needs and how much is being provided. And those usually you see them in things like sepsis, and tachyarrhythmias, and then severe hypertensive crises. They have type 2, 3, and or type 3, 4, and 5 MIs as well, but those are all like post-CABG MIs or diagnosed post-mortem. For what everybody thinks about when we say heart attack, that's actually a type 1 MI, that is acute coronary syndrome. Now, when we're trying to figure this out, people don't come with labels in the ED, they just come in with chest pain or some other equivalent complaint. They feel short of breath, epigastric discomfort. And so when we risk stratify, usually we start with the EKG, and that is basically the EKG in the history and biomarkers, which is a troponin, which will determine if you were having an actual heart attack or not. So the EKG, basically, it'll show in 3 broad groups of changes. One is a ST elevation, and this is that's 100% occlusion of your coronary artery, and that's a medical emergency. You have to get that basically the more time you wait, the more heart that dies. So you have to move as fast as you can to either get them to a PCI center or percutaneous coronary intervention to go to the cath lab, and that's what we do around the Bay Area. If you were working somewhere up in like, I don't know, Eureka or Ukiah or something, and you didn't have availability of a cath lab, you'd basically give them fibrinolysis or TPA, or there's a few other ones. But we don't do that in a major metropolitan center. It's basically you need to give them to a STEMI receiving center. So moving a step down, it's basically what we call an NSTEMI/unstable angina. And this is basically a ST segment depression or T-wave inversion on your EKG. The whole thing between unstable angina and NSTEMI, they used to be lumped together. What it was NSTEMI was EKG changes, ST depressions or T-wave inversions, and you have a positive troponin. That is a biomarker. They used to use CK, but they don't anymore. That was back in the 80s and early 90s. And that would be termed an NSTEMI. It turns out that if you had a concerning story, and you had, like, let's say you have an 80-year-old guy with hypertension, dyslipidemia, and he smoked 2 packs a day for like 50 years, and he comes in with crushing chest pain and dyspnea on exertion, so it's a pretty good story, and he has ST depressions in his lateral leads. Well, you think that's an STEMI, but he has negative troponins. The whole term unstable angina is probably something that it's not actually apparent anymore. The reason for that is the troponin assays that we used to use are not as sensitive as the ones we use now. So before, you'd call that negative troponin, but a good story in EKG changes, you'd be like, that guy's having a heart attack, and you treat him as such. We've gone back, and actually studies have looked at the blood samples that they've saved from those patients like 10, 20 years ago, and then run them with modern assays, and they all turn out to be instant because they have positive troponins. It's just we weren't sensitive enough. So unstable angina, honestly, with modern day sensitive troponins, if you don't have it, it's probably something that's not an entity anymore. So it's hard to convince a cardiologist, to do anything on somebody that has only minor EKG changes and negative troponins. You have to have a really good story or a really good reason why they need further intervention, like a cath. But at the end of the day, let's say you have none of it. You have no ischemic EKG changes. You have negative troponins. Then usually what we say is likely non-ACS, non-acute coronary syndrome related chest pain. The caveat there, it still could be. You have to do a little more risk stratification for that. But we talked about STEMI. So the diagnostic criteria for this is 1 millimeter ST elevation at the J point and 2 contiguous leads, set V2 and V3. J point is basically the inflection point right after the QRS complex, where the T wave or the ST segment starts swooping upward. Do we have markers? I'm going to draw this. How do I get this up?
I don't know. Oh wait, can you draw it on paper?
Yeah. Oh, this will be fine. So basically, here's your QRS complex. You have your P wave here, and you have your S here, and then you have this area here where it starts to go whoop and down again. This area right here, that's the J point. So you're measuring at the J point, so right here compared to your baseline. Some people use this as a baseline. Actually, technically, it should be this as a baseline. For your point, doesn't matter. So basically, 1 millimeter here of ST elevation and 2 contiguous leads. And then it has to be a little higher in V2 or V3. Think about 2 millimeters. It's just naturally a little higher in that one. So that criteria. Now, the unfortunate thing is, they're not exactly 100% sensitive, nor are they 100% specific. You can, of all the ones that meet criteria taken to the cath lab, about 14% of them have normal coronaries, so they're not actually heart attacks. And then also these criteria will miss other subtle STEMIs, or what we call STEMI equivalents. And I won't go into that too much because that can kind of get complex. So, but they're good enough that this is like the accepted definition. Now, this is classic STEMI. This is basically you have ST elevation and your precordial leads here, V2, V3, 4, 5, V4, a little bit in V5, and then also laterally. So this, and then reciprocal ST depression and inferior leads. So this is a classic, probably a huge proximal left anterior descending artery LED lesion. That needs to go to the cath lab soon. You also see these, you're starting to get Q waves here too. Basically, that means this has been going on for at least a decent amount of time, and you're already starting to get, you have a bunch of dead myocardium, but still you need to act on that fast. So that's an emergency. But these are kind of tricky. So this is another one that, well, this could meet criteria for an ST elevation. It might. It isn't. This is in V2 or V3 and V4. That's 1 millimeter of elevation. So, well, that was about 2, and that was about 1. So that would fit. But this is actually something called benign early repull. We see this in young women and young men all the time. It's hard to tell the difference. You have to just read hundreds of EKGs, but it has a sharp inflection point. The T waves look fine. It's like actually teaching residents to do this, it takes years to do many EKGs. So once again, this is just, they're not exactly specific. This one looks bad. This one is not a STEMI. This is actually massive left ventricular hypertrophy. The lateral ST depressions and T wave diversions are actually what's called a strain pattern. That is, there's so much myocardium, so much voltage in there, it distorts the repolarization. So that one looks like a STEMI. Now, for your point, if we get somebody here that has that EKG and complaining of chest pain, let's say grandma, like was visiting her granddaughter and had been in a horrific car accident and got upset and she felt some chest pain. We get an EKG and we see that. I don't have a prior one on that. You know, I'm gonna get that patient out of here as fast as humanly possible. And then I've had to sometimes when I don't have priors and I'm like, I don't think this is a STEMI, but I'm like, man, this still looks kind of ugly. I still have activated the cath lab. Sometimes the cardiologist will be like, nah, I think they're okay, let's do something else, let's get an echo. Sometimes they're like, well, we just gotta go take a look and do it. So I think it's easier to like err on the side of caution, especially if you're not very familiar with it, and then treat it as a STEMI if you're at all worried about it. It's better to be like, people will be like, you know, they'll never forgive you for if you be like, you know, that patient with crushing chest pain, ST elevations, you thought was like something that wasn't a STEMI. Well, it turned out to be a STEMI. They won't do the opposite to you if that makes sense. This one's another one. This is a mimic. This is called Brugada syndrome. It's a sodium channelopathy. It causes sudden cardiac death from DTAC and BFib. But you get these shark boys in V1 too. You'll see this in kids sometimes.
Yeah, I can say we had a patient with that.
Yeah, it's mainly Southeast Asian, but it also will be in anybody too. But this one was from Stanford. When I sit down, I review all the cath activations with the cardiologists for years, and so this is one they activated. One of my colleagues did. Cath and coronaries were clean. Then the cardiologist was like, "Wait a second," and
So that's V1, V2, two contiguous leads, right?
So
and the J point is
the J point's right here. The J point's right here, and this is at least several millimeters of ST elevation there.
Yeah.
And a little bit there too. So, you know, technically wouldn't meet criteria, but I can tell you that is not. Looking at that is a classic type 1 Brugada syndrome. It looks like a shark fin here. And the guy actually presented with feigning. Usually people that have heart attacks, they don't present with feigning. Feigning is usually an arrhythmia, which is the problem here, because he went to DTAC or BFib. He got a defibrillator. So let's say we have somebody that we think is a STEMI. So basically, the goal is from first response time to getting to like the needle time when you puncture their groin within 90 minutes. So you need to get them out of the ED as fast as humanly possible. So don't do anything at all that would delay transport. You want to get a chest X-ray? Not going to matter. Unless you think it's a pneumothorax or a dissection. That'd be pretty rare in this case. You can. So basically call 911 for re-triage, get IV access and just hang a liter TKO on them, give them 325 of aspirin, and then you can give some sublingual nitro, basically as long as they're not bradycardic or hypotensive. Sometimes they'll pick off, like an inferior STEMI will pick off if it's a real proximal, will pick off the little feeder vessel to your SA node and AV node, and you'll go into like a hydrogen block, or you'll zot out your right ventricle, and so the right ventricle can't squeeze and you're preload depending. So you don't want to give nitro if your RV is not working, if that makes sense. And also check the potassium too. There's a lot of things that look whack. Potassium is basically the syphilis of for as far as EKG changes. It can cause lots of like hyper and hypokalemia can cause lots of weird looking EKGs. So I usually like to get a potassium. So if your potassium is like 8 and it's not hemolyzed, or it's like 1.2, yeah, it's probably not going to be a STEMI. It's going to be some weird EKG changes. So always just remember potassium, especially in adults. So basically,
if it were like a potassium and electrolyte issue,
yep,
we wouldn't try to normalize that before transport.
it depends. If you're dealing specifically, the one that you'll go from alive and talking to dead within minutes would be hyperkalemia. So if you have somebody that's a K greater than 6.5 in an adult, even if they're asymptomatic, I will shift them. That is, and that's usually a couple amps of calcium gluconate or an amp of calcium chloride, and then plus some bicarb if they're acidotic, plus some Lasix, and then basically you need to stabilize them, because if you don't, I've seen them go like, they're talking and then they're in BFib arrest. So not to get too far afield, but the only one I would treat here would be hyperkalemia, because it's going to be a little bit before they can get dialysis. So you need to actually both temporize the myocardium, that is calcium and bicarbonate, and then try to shift it. Usually that's insulin, glucose, and Lasix, and albuterol in rare cases.
I was going to say, is this the one we do albuterol as well?
You can. Albuterol, you save it. If you have somebody that's like missed his dialysis and his potassium's like 6.7, he looks good. Usually those people are a little more tolerant, so you can usually give them insulin glucose. You give them some Lasix if they're still P, and some bicarb because they're usually acidotic. It doesn't work if you're not, and then a couple amps of calcium, and that'll kind of temporize when we get arranged with your nephrologist to dialyze them. I usually use the albuterol when it's when they like come in like 8.4. I had some lady that looked like ashen death with like DKA, sugar of 800, renal kidney failure, creatinine was like 3, and like potassium was like 7.4, acidotic, like bicarbonate. Like that person was gonna like die soon. So that was the one you chuck albuterol in, and you basically do like a continuous snib on them. You do 15 an hour on them in adults, so you need to actually have a lot of albuterol. And we all know this too because we occasionally will check these iStat panels on these kids that we've been running for 2 hours on albuterol. The potassium's like 2.7, and everybody like goes nuts, but it just
What is the albuterol doing to actually lower?
What it does is it shifts it intercellular. So when I say shifting, what it does is it takes intercellular and extracellular, and albuterol pushes, and I don't know what mechanism, but it basically takes all potassium. Most of the potassium exists in intercellularly.
Right.
Extracellular stuff, it basically takes it and shoves it intercellular. So that's what albuterol does. So that's why all these potassiums are really low. Albuterol, it causes also a lactic acidosis, not from hypoperfusion. So this is why sometimes like residents or trainees will go nuts when they get this iStat panel on like the kid with it's like 2 hours on, it's been asthmatic, 2 hours on albuterol. I don't want to see the lactate at like 6 because I don't care. It's not like, it's actually not something that it's a side effect of the medication. The potassium's 2.7. Once again, I don't care about that. But if you have hyperkalemia, if you want to give them a little bit of albuterol, it won't hurt. You know.
Does that do it faster than insulin and glucose?
Not basically what will work.
So it's just on top of these.
It's on the top. So
treatments.
basically, everybody in my book gets calcium. If you're acidotic, you get bicarb because it doesn't work if you're not acidotic. And then they all get insulin and glucose. And if they compete, they get Lasix. There's no role for KX-late. That's made of fairy goodness and actually has more harm than good. If they're really bad off, then I usually like once you get past 7 or so, I'll probably give you some albuterol as well. You're gonna maybe each one of those interventions is gonna drop it by 0.5 to 1 milliequivalents roughly, and it's a temporizing measure too. You still have the potassium in your body. You have to get it out, which is either Lasix or you get dialyzing. So just keeps them from dying. So.
And you said the KX-late doesn't really help?
KX-late, when they mix it with sorbitol, has been associated with like intestinal ischemia, perforation. And the thing is, the data that it's based on is very poor, very old studies from back in the 50s or 60s, and it doesn't really, it's unpredictable, and it doesn't really work for like hours. So if you give somebody KX-late for a couple of days, sure, you can drop their potassium a little bit, but that's like if somebody's dying, I haven't turned
Not
as a
gonna work
doctor,
right
like
now.
give them some KX-late. Well, dude, that's not going to work within like, I don't know, hours. So the guy's like, we need to do something that'll actually work rather than something that has little, if any, proven benefit and has some downside to it. So occasionally I'll give it to if I have a guy that like he skipped his dialysis or he had a little extra salt or sodium or whatnot, and he's a little fluid overloaded, and he has dialysis the next morning. So I give him a little KX-late overnight, and maybe I'll like him, but I still give him some other stuff too. So anyway, so STEMIs basically get them out of here. Do we have heparin here, by the way? Okay, you can give them a slug of heparin too. Don't start a drip because the transport teams, they can't usually take drips and it complicates them. So if you want to give them 12 mg per kilogram of 12 units per kilogram of heparin up to 4,000, just like a bolus, you can do that too. That's fine as well. But you don't really need to.
I don't think we have that much in Texas.
I would
Yeah, we
honestly,
have the
if
little
you're not
ones.
familiar with it and you don't have it there, I wouldn't waste time. Anything that delays like getting them in the ambulance and packing them to whatever, I don't know, all debates or something. I think maybe
I
probably
think it's
debates.
Summit, probably.
Summit,
sorry.
the STEMI Receiving Center is like, you're just shooting yourself in the foot. Don't get labs, don't get a troponin. By the time they come back, you don't care. Get an iStat panel. But that's about it. So let's talk about NSTEMIs. So these are basically, you've got a plaque rupture, but you got less than 100% occlusion. And what these are basically ST depressions or T-wave inversions in more than 2 contiguous leads. Okay, So just think ST depressions and T-wave inversion. Once again, these aren't 100% sensitive or specific for, there's a lot of other things that can cause ST depressions or T-wave inversions. You can just have them normal on your EKG, but you don't know it because if it's the first time you're seeing the person, you don't have a prior one to compare it to. Or it can be electrolyte abnormalities or a whole host of other things. So this is an STEMI. So basically, this individual's got some lateral T-wave inversions here and here, more than 2 millimeters, a little one here, not too sold in that one, and laterally here too. No ST elevations as well, no ST depressions in that. But so this was like a 50, 60-year-old guy that was complaining of chest pain or trouble breathing. This is a guy that's going to get some aspirin and heparin drip. This is also an ST elevation MI here. Anytime you have ST depression, you always want to look in reciprocal leads, which is basically inferior and lateral here, to see if there's any ST elevation. Sometimes it's ST elevation of reciprocal depression. But this one is just depression. So you have here ST depression, no ST elevation. So this person, if they're like having chest pain or equivalent, is that's an STEMI. So also a couple things, kids, I say residents will get fooled on. So once you get a really tachycardic, you can get ST depressions. You see this commonly in people in SVT or AFib with RVR. They'll have all these ST depressions. Don't care about that. Like, it's only once you control that rate. So these are rate-related ST depressions because heart's just going so fast. You'll see this in the immediate cardiac arrest post-period. So if you get somebody back too, you get the initial EKG, and you're gonna have some weird ST depressions and little elevations on it. So usually you let, like, if you get it within like 3, 5, 10 minutes or whatnot, it's going to look a little wackadoodle. You still do it. If you see a huge STEMI, then you can activate the cath lab in that case, but usually you need to wait like 20, 30 minutes, get another EKG after that, and then it'll kind of see where you're kind of nadir out at, and then make your decision on what you need to do. But you're already doing a ton of stuff at that point in line. So this ST depression, don't worry about it when it's rate related, okay? Basically, let's say if we have an STEMI, what do we do? So usually you don't need to call them lights and sirens, but they do need to go over urgently. These people don't go to the cath lab they go within 24 hours, and they only need to go like emergently if they've got like they're they're hypotensive, they got overt heart failure that's brand new, or they're having like runs of VTAC or persistent ischemic chest pain despite all medical therapy, Plavix, aspirin, heparin, nitro drip, nothing's working, then they need a cath lab. So anyway, what do? Well, get IV access, hang a liter saline TKO. It's always good to have some saline around because you can squeeze it in if the pressure gets a little soft. Give them aspirin, give them some nitro. You can give them heparin as well. And then basically same thing as you do with all the other ones. So don't make it anything fancy. You can send some labs if you want, but I would just get them over to adult center and they can repeat all that and do it in-house. Because at a certain point, you can't give definitive management to this patient, so don't waste your time too much.
So at these, like in your adult ER, is this
Yep.
something that the nurse would just, at these orders that they would automatically do before you saw them?
They probably wouldn't do it. Some depends on their, they'll give, like they have some standing orders for like chest pain, here have an aspirin or nitro. It totally depends on your system. Usually they'll recognize it. They'll like be at the bedside when the patient, the EMS rolls in. They'll be like, oh, and they'll come and grab me, or they'll get the EKG. Usually it's the techs that do the EKGs. And they have to bring it with it to attending immediately, and then we sign off on it too. But I've had all scenarios when they're just like, I think this guy's having a heart attack. And I'm like, yeah, he's having a heart attack. And
Yeah,
he's having
I've
a heart
had a
attack.
guy who came in for bilateral elbow pain and was having a STEMI.
Yeah.
I'm just like, roll him up, get him out of here.
The interesting thing, the whole like crushing substernal chest pain rating to the left shoulder and feels like my last heart attack. The likelihood ratio is actually, that is, whether each one of those symptoms increases or decreases your likelihood of having a heart attack, or classically taught in the textbooks, actually is not accurate. The things that are highly accurate are if you have exertional chest pain, like, doc, I go up the stairs and my chest hurts and it feels like a boulder sitting on it. Okay, now you got my attention. If the patient is sweating in front of you, if they're like diaphoretic and beating sweat complaining of chest pain, also highly sensitive. If it's more right-sided, not left-sided chest pain, it's actually much more sensitive, and if you have radiation to one or both of your shoulders. So if I have a guy, it's like I get this pressure in my chest when I go up the stairs, and it goes to both my shoulders. Okay, now my ears are perking up, and like this guy is gonna have to really try to sell me to go home because he's most likely not going home. He's gonna go to the cath lab sooner than later. Oh, if he not just nausea too, but active vomiting in front of you. So if they're barfing in front of you too, complaining of chest pain, it's not just like belly pain. That's also worrisome. We talked a little bit about unstable angina. Basically, unstable angina of yesteryear were probably STEMIs in using modern assays. Does that all make sense? I'll draw this up. This will be real quick. So this is your troponin level here, okay? Or the level you can detect it. And this is time here. So let's say this is time 0. So let's say at a certain point I have a heart attack. And then let's say it's a huge one. So my troponin goes up like this, and then after a while it goes back down. Or I can have a little one. You know, I only whack off a small branch and it goes The troponin assays before, they were only sensitive to pick up, let's say, I don't know, I'm going to make it up an arbitrary number, 10 of troponin. So the ones in 1990, anything below this level here, they'd call as negative, right? So this little one they wouldn't detect.
So you didn't know you had it.
Yeah, so they'd call that unstable angina. You have EKG changes, you have a good story, you're an old vet with hypertension, diabetes, and smoke 2 packs of cigarettes a day. Yeah, we're going to treat that as a heart attack, and that's an unstable angina. Turns out the sensitivity of our troponin assays are so good right now here too, they're almost bordering on crazy. So they'll pick up basically anything. They have a new one they just FDA approved. It's called a high sensitivity troponin. They've used it in Europe for a couple of years, but I think they can detect picograms. So basically the thing is they will detect everything, and that means like any person that comes in with a old lady with a little pneumonia is going to have a positive trope if you check it. And so you're going to have it's going to be not very specific, which is going to be a problem too when you're trying to figure out what to do with so you have a guy that runs a marathon, he'll have a positive troponin. I don't know, he just ran a marathon. I don't think he's having a STEMI or ACS, but he's this is the thing that usually this we call unstable angina, now would be called an STEMI. So a lot of people unstable angina is not something we typically think about. Basically, you have to have EKG, just troponin to by yourself intervention. So what about this guy? Is this guy having anything? No, this is a normal EKG. Could it still be ACS? It's possible. I don't know. I basically need to watch him for a little bit of time and get serial EKGs and troponins. Sometimes you need to get a provocation test like a stress test, but not always these days. We can get pretty good at ferreting out which ones do and don't need that. So what do we need to do? Let's say this old lady has chest pain in the ED and we get this EKG and it looks okay. Well, can I send her home? No. I still need to do a few other things on her. And you watch her for a little bit and repeat things. But what do we need to do? Basically the same thing as we've done. Give her some aspirin, give her some nitro, send her to ED. Oh, one other interesting thing about nitro too. Your response to nitro or your lack of response doesn't dictate whether you're having a heart attack or not. So if you get better with nitro, doesn't mean you're having a heart attack. You can have GERD and get better with nitro. The corollary to that is also let's say you get a GI cocktail and you feel better. Does that rule out a heart attack? No, it doesn't. You can have a heart attack and feel better with a GI cocktail. So your response to therapy doesn't really matter at all. So you can give morphine, give a GI cocktail, and give a nitro. We assume that if this is a heart attack, nitro will dilate the coronary arteries, improve the flow, so it will help. So give nitro. Tell them it'll cause a headache too. Okay, let's talk. Yeah, it does. My head hurts. Let's talk about arrhythmias real quickly. Okay, we'll do some cases. So let's say we have an 85-year-old woman. She has some heart disease, and you don't know what that is. She's a poor historian. And she kind of felt lightheaded when she was visiting her daughter. They were drawing blood, granddaughter was screaming. So they sent her to us, and she's got a heart rate that's elevated, and she looks okay. She's got a regular rhythm, no murmurs, got little crackles in the bases of some edema. And she's like, my legs are always kind of swollen. You're like, okay. And you get this EKG. So what is that? So that's kind of ugly, and probably you guys don't like that, seeing somebody with that here. So this is basically an irregular, narrow complex rhythm. And this is a FIP. I don't see any P waves here. Some of it looks a little regular, but here, this is all a little irregular. And so this would be a FIP with RVR. So what do you do with this? And basically you just go down to your adult tachycardia with the pulses. Do you guys have to take ACLS at all?
Not here.
Not here.
Yeah.
Okay. So
Some-
this
some
is when I was looking this up, I realized when I first did this in 2006, I had to blow the dust off my old cards. I was like, wow, they've done like 4 or 5 iterations since then. And I'm glad because some of the data is actually, I was like, before I was like, I didn't like using that. Now I was like, okay, now the recommendations. Usually the recommendations lag the data by like 5 or 10 years. So basically you go down, this is your ACLS algorithm. And honestly, rather than going over like understanding the intricacies of AFib and how do you manage that in ED, honestly, if that happens here, you can't provide definitive management, so you just want to stabilize them, do what you need to get them to a safer place, and let somebody else that's better equipped deal with them. So basically you go down with this. So this person, the persistent tachyarrhythmia causing hypotension, no. Acute mental status, no. Those kind of go together. That is your hypoperfusion in your brain, signs of shock. Ischemic chest discomfort, when you get AFib with RVR, they're like, my chest feels like some fluttering or discomfort. Is that a heart attack? I don't know, so I don't really count that one in there. And then acute heart failure, sure, this lady probably has some degree of chronic heart failure. I don't know if it's acute. Like if she was in like florid pulmonary or edema and guppy breathing, okay, then you have my attention. But that's, so I don't, those last two are kind of like semi-soft ones, whether you need to like cardiovert. The other thing too is when you cardiovert like AFib, a lot of times whatever caused the AFib is still going to be around, whether it's like electrolyte abnormalities or just bad heart or ischemia, fluid overload. So they'll go back to AFib again. So you need to actually like just cardiovert is not sometimes like, yay, fixed it, and then you're back in there, and you're like, no, that sucks. So you basically go into your algorithm here, and down below is, so they don't have YQRS, they're not hypoperfusing, so you can try adenosine if you think it's SVT, that'll always be fine, or you do a beta or calcium channel blocker. The differential for like a regular narrow complex is usually A-flutter with variable block, AFib, and then multifocal atrial tachycardia, but this one has no P waves. Multifocal atrial tachycardia is like old COPDers. They've got multiple different P waves, so they're basically their atria is firing a bunch of different foci, kind of like AFib too. So here, you could like, unless anything less than 150 in adult too, if they're having like hypotension, your heart rate's 130, is not due, and like they're in AFib with a heart rate of 130 and they're like hypotensive to the 80s or 70s, the AFib isn't causing that. There's something else causing it. You usually have to have your heart rate at least be 150 to be cause some kind of hemodynamic compromise. So this lady here, what would you do with her? 220 would be.
I had SBT. It was up to 220.
Yeah, well that can cause some problems. So,
Scary.
AFib with RVR. So 150. This is a stable patient. Give him some oxygen, never will hurt. Give him some aspirin, never is going to hurt. You can give a small bolus of DILT here if you want. I don't even know if we have
Love
DILT,
that drug.
but you can give DILT if you have it. You can give him a toprol too, that's fine.
think
But
we
mainly
do.
just get him out of the ED.
We don't have DILT.
Yeah. So if you don't have it, that's fine too. And then I just get him out of there. So you don't really need to do much
But you
with this
wouldn't
one.
give adenosine for 150.
No, I probably wouldn't. So usually I've seen some SVTs, like I had one actually a patient here, a mom, that went to SVT, but her rate was like 140. It was odd, but it
Oh,
was,
really?
she had something like this before, and she didn't follow up with a cardiologist. So I sent her to Alter Bates. They didn't want me to give her some adenosine here. I kind of wanted to play with her a little bit, but anyway. So we sent her to Alter Bates. They gave her adenosine.
Adenosine's no frickin' joke.
So
Worst drug ever.
feels like you got to tell your patients they're going to feel like they're going to get punched in the chest, and their heart's going to stop because it is. Oh, do you get it, Betsy?
Oh, that
I
face
did.
though.
What did it feel like?
Let me tell you real quick what it felt like. Okay, you're on a red eye going to the East Coast.
Yeah.
It's dark and stormy out, and your plane's going down, and you have to jump out, and you don't have a parachute.
Oh,
That is how adenosine feels.
Like your heart's going to stop.
scary.
Twice.
Yeah, it doesn't feel.
You got it twice?
Just warn your patients.
I
So.
couldn't get it.
And this one, you don't basically have to do anything with this one. Sure, the heart rate's fast, they're stable, so just get them out of there. Reality of what I do is I diurese this lady a little bit, give her a little bit of DILT. If I just give her a huge slug of DILT and put her on a DILT drip, actually she's going to have more bad outcomes when they looked at it. So you want to diurese her, check buffer lights, and then slowly rate control.
Really? Because they gave me adenosine here twice, and I was still in SVT, and I went to Kaiser Oakland, and they started DILT.
Yeah, you
IV
can.
bolus
So
and
basically,
Congo.
if it's like,
Heaven.
if for SVT, so basically it's vagal maneuvers, they don't work, adenosine again, adenosine for the third time. Well, that ain't working. Then you can usually do another nodal blockade agent. Used to be verapamil. You can use DIL. You can use metoprolol. You can just shake your dice and pick whatever one you want. But basically, you have a reentrant tachycardia. It just keeps going around, and you have to block it.
Why would they use adenosine first if it seems that
It's
it would convert
for
them
oh
for SVT?
Yeah, why not cardioverter?
Why, well, no, that would be even worse.
No, I mean after the
Cardioverter
adenosine and
Adenosine.
before the DIL.
yeah, I usually do adenosine. That doesn't work. Then I usually go to like DIL to metoprolol after that. And if that doesn't work, then I'm just gonna cardiovert you. Which I like cardioversion. It's easy and it gets the job done.
But why use adenosine before DIL?
Oh, you wouldn't? No. Oh, or why use adenosine before DIL?
Yeah, why?
Adenosine is short acting, so basically it lasts seconds. Well, DILT is last hours. So I think I think they would both be efficacious. And I think they've both been proven to. But for something that you can stop and it's not going to recur again, for the most part, then using something that's short acting is better than giving them a slug of something that's longer acting. Sometimes like people when they get overzealous at like controlling AFib and stuff, you can like sometimes they'll convert back to sinus and then they'll be hypotensive. So I'd use the shorter acting one because it just wears off. It's just an on-off switch pretty much. So let's say we have this one right now. Same thing, but this time she's kind of pale looking, a little sleepy, and she's hypotensive and her heart rate's a little higher, 180. Looks kind of like that. So this one is unstable. She's altered, she's hypotensive, a little shocky, maybe she's got a little heart failure in there if you want to count that. So what you do is you cardioverter her, and I wouldn't wait. So as far as like consider the sedation, basically you want to sync cardioverter. Sync if you can, because otherwise sometimes you can send them to VT if you just defibrillate them. Once again, that's pretty rare. So, but if you can sync them, sometimes the computer just can't sync onto it. It's like so irregular, and they just have to cardioverter them, and that's life. I put pads on her, cardioverter 200 joules. They say between 100 and 200. Honestly, I just go big. I go big or go home in my book. Everybody gets 200.
Ouch.
Yep.
Dang.
Other thing is if you have somebody that's morbidly obese, what you can do is take a towel with your gloved hand and put it on their chest and crush the pacer pad down on their chest too. Gets better contact to cardiovert them too. That's what the cardiologists do all the time when they're upstairs doing TEs. If they're really like hypotensive, I don't really bother. Like you don't want to bother with the time to like get a just like a propofol up or a half dose of etomidate or something to fully like put them out. I give them a little Versed as well. The Versed not going to fully put them to sleep. What it does is it'll wipe their memory for the last few minutes, so they won't remember it.
But they feel it.
Yeah, they'll feel it, but they ain't gonna remember it. So, but what you're dealing with is like in the hierarchy of needs, keeping somebody alive takes precedence over their comfort. So if I need to do something terrible to somebody and it has to happen, well, it's gonna happen. These ones too, just as a side, I tend to give MAG. I think AFib likes MAG, and so give some MAG. I give a little bit of bolus too. She has a little bit of failure, but I don't know if maybe she'll be responsive to a little fluid or not. If she's borderline hypotensive, might be the heart rate too. So you can give a little bit, just don't give a lot. And then I like phenylephrine as well. One thing that these people get unstable when you get AFib this high is what happens is you're squeezing your heart so fast that during diastole, that's when your coronaries fill. So you don't have enough diastolic filling time to perfuse your coronaries. So the heart's somewhat ischemic in this point, which makes it more susceptible to go AFib. So it's kind of a vicious circle. So you need to slow the heart rate out. Sometimes you'll shock them out of it and they'll go back into it. So sometimes you have to use like little spurts of DILT to bring the heart rate down a little bit. And also what I do is I use phenylephrine because it's just a pure alpha agonist to increase the blood pressure a little bit. So you just cause a little peripheral squeeze to hopefully give a little more perfusion to the coronaries. I don't like using things like epi because that's just going to whip the heart and make it more irritable and then propagate your AFib with RVR. So that's one of the only rare times I like phenylephrine. AFib with RVR and they're hypotensive, but shocking. Okay, moving on. Let's say got a food service worker. He has 5 stents and heart failure. And he developed palpitations and chest pressure. And they send him to the ED. And he looks pretty good. He's got a little pity and edema. And he's like, can I go home now? And you get this. So
what do you want for your last meal?
yeah.
Seeing you just came from the cafeteria.
Yeah. So this is, what is this? So basically, it's a Y, even if you don't know what it is, there's a few things. So this is a Y complex regular tachycardia.
Oh,
Differential for
really?
that is VFib,
Yeah.
SVT with aberrancy, or any kind of like supraventricular rhythm with aberrancy. Could be A flutter with aberrancy. Aberrancy means like you have an underlying bundle branch block, and then like you go into SVT, so it looks like VT. Basically, there's all these complex algorithms where you can determine. You spend lots of hours like looking over the EKG and stuff, and nobody remembers all of that. Basically, anybody that's old that has heart disease, or anybody that's old or has heart disease, it's more likely VT. Just treat VT, because if you don't and they have VT, they could die on you. So just treat it like VT. So this guy is stable. So you have some time. So I am personally a proponent of cardioversioning. I would shock this guy. Like I would get an antiarrhythmic drip, but I would have pads on this guy and be ready if like he twitches the wrong direction, I would just zot him. If this guy, since he's awake,
He looked like he had an arrhythmia though. How do you know where to?
Would it be synchronized in other
Yes,
words?
it would be synchronized.
Because
Basically,
you have an organized.
an organized rhythm. The only time that it's gonna be defibrillation, that is just you shock them and it's not synchronized, is if it's VFib, because the computer can't there's nothing to it's just hash, and so there's nothing for the computer to sync to. And then polymorphic VT, sometimes you'll get a really disorganized, chaotic rhythm that it can't, like AFib that's super high, like Wolf Parkinson White, and then you just defibrillate him. But this guy is stable, right? So you have time. So one thing is you could either use amnio or procainamide. We do have procainamide. Do we have amnio?
Oh, we do in the
Yeah.
hospital. I don't think that we have it down here. We would have to have
Might be in
pharmacy.
the co-cards because it's in town.
Yeah, we should
Oh,
have
the pharmacy
amio on the code card.
Yeah.
I don't
Amio
think
or
so.
no?
I don't think
It's
so.
actually in the red box. I took a picture.
Oh, is it?
Yeah, I'll go over all
Oh,
the
great.
meds we have. But we do procainamide actually is better than amiodarone, just as for converting less side effects, but people don't use it. Amio is like the thing. But you can do that. So if you want to start a drip, that's fine too. Personally, I like cardioversion. If you're going to sedate this guy, what I do is I'd use propofol, like 0.5 to 1 milligram, or basically a third of an intubation dose of etomidate. So like 5 or 10, just make them out a little bit, and then zot it.
Hello.
We're still in the lecture. The staff meeting is next. That's why we're.
Oh, that's okay.
People
I can
are
keep going. I've got lots of slides. So VT, and then I would basically, I think
Yeah.
as an emergency doc, I love airways, I love cardioversion, I love sedation. So if you want to shock this dude, perfectly fine. As far as pad placement too, they use two things in adults too. So you can go here and here, but actually don't do that, because sometimes people have they're so obese that if you put it here and here, you're just actually barbecuing. Sorry, that sounds mean, but you're basically cardioverting fat tissue. So you actually need it to go through the heart. So what you do is you put one in the back and then one in the front. That's proper pad placement. And if they're really obese, you put a towel on them. You have your gloved hand when you cardiovert them. Usually they say charge and shocking. It won't shock you. Fine, I've done
Too
it.
much.
No, I've
I've
seen
done
it like in the ACLS where people
Really?
are just hands on the patient when they don't even say clear and they're shocking.
Yeah, just you have to make sure your glove and then also buff your lights. They don't like hypo-K, hypo-mag, and hypo-cal in VT.
Fill up.
Thank you, Tom.
No problem. Thank you, Betsy. Here's a resident that didn't sleep and had too much caffeine and felt their heart get fluttery.
Yeah, that's probably what mine looked like.
Yeah. So narrow complex, regular, SVT. So adenosine for this one.
Hi guys, this is Kim Ross.
Hey Kim, we're waiting for Stacy and Teresa to show up, so Tom's going to continue until Stacy and Teresa show up.
Do you want to talk about tachyarrhythmias?
We're talking about tachyarrhythmias. It's really very good, actually.
So are you guys set up for the meeting to start? Because
Yes.
Dina's on the phone for the staff meeting.
Yes.
Okay, I'm gonna let you talk to her and I'll come back in a few minutes and get the phone.
Yes, we're doing the lecture until Stacy and Teresa show up.
The only time you don't want to get adenosine, by the way, or like in higher doses in kids
877,
with people that have heart
820,
transplants, because since they've severed the
820,
parasympathetic and sympathetic
78,
system, They'll get a lot, like give a
7831.
big slug of adenosine. It's mainly
And then the
for kids with heart
participant
transplants.
number
They
is
will go
124.
asystolic for a long period of time. That's not a good thing, so you need to use like a
Okay,
baby dose of that.
Okay.
So just keep
Heart
that.
transplant, no.
okay.
Yeah,
Alright.
heart transplants don't give big slug of adenosine if they're an SVT.
Okay.
Usually if they're stable, talk to a cardiologist too, because they got some wackadoodle rhythms. And this one too is like, they tell them to not caffeine. Usually SVT is like they have a reentrant circuit at baseline, and they have a PVC that basically kicks it off. So anything that causes PVCs, in this case like a resident drinking lots of caffeine, then you cut back on the caffeine, get a little more sleep, and then buff your lights. And adults, we send these people home, like young adults with SVT, just send them home. They don't need any like restratification for heart attacks or anything. Okay, so let's see, do a couple more here. So we got an 80-year-old woman. She done fell out after she saw a granddaughter by a trauma. Heart rate is low. She looks okay. So you look at that and everybody freaks out. So this is, so we got P waves here. So the main thing to get a bradycardic is what are your P waves doing and how are they related, or do you have P waves and then how are they related to QRS complexes? So here it's a sinus rhythm, P waves up and 2 down AVR, and every P has a QRS. So this would be sinus bradycardia. So she's stable, no signs like ischemic chest pain, heart failure. So do you need to do anything? No. The question would be like, is she taking a lot of metoprolol or something? Does she need to come off of it? Did that really cause her to faint? I don't know. But what you're going to do is you're just going to send her to a doctor, and they can figure it out.
Okay. We gotta switch over.
Okay.
Switch. Did we get to asystole?
Thank you.
That's